Good morning. I'm here to talk about Penumbra Indigo. Let's see if, okay, here we go. Here are my disclosures. And the one that's relevant to this is I'm a consultant for Penumbra and the site PI for Bolt. Dr. Desai, who our first speaker, is the national PI. So as I introduce the case that I enrolled into Bolt, hopefully he's happy. We talked about a lot of this, the goals of venous treatment and why we do it, so I'm going to skip over that. Ultimately, in the real world, when the patient comes in, we used to do thrombolytics. They were powerful, they worked very well, but 5 times higher bleeding risk. You can't do it in a single session. Oftentimes, even if you're going to do an abbreviated portion, the patient goes to the PACU for a long time with a shortened lysis period and they come back. That's expensive. Patients go to the ICU. And there's a whole bunch of relative contraindications in addition to the major ones that we had talked about. And ultimately, because of some of these limitations, it will limit how quickly you can get to treat that DVT. Why is it important to treat the DVT? And I love kind of what the first 2 speakers were talking about. Acute clot kind of looks like this, nice jelly kind of pudding thing that you feel like you can take out really easily. The subacute ones become a little bit more organized with some collagen in it. But as you become chronic, chronic DVT is my least favorite term. It is like scar tissue and collagen that's stuck. It is not a clot that's sitting in the area, and that becomes excessively difficult to take out. So as a result of this, trying to get to your patients who have a DVT early is important so that your success and technical success for this could be higher. Many different devices you'll talk about, we'll hear about even in this session, and I encourage you to stop by all the vendors. Everyone brought their demos, so if you want to get a hands-on feel of how every single company has a thrombectomy, and literally every company has a thrombectomy device today, so see how different things work. Penumbra is my current favorite device that I am using, but it has not always been. It's been around since 2013, and the first generation from 2013 to 2017 included this family of just straight tubes. Penumbra came from a neurovascular space, and they took the same kind of neurovascular technology into the peripheral space, and they had everything from a Cat 3 all the way up to a Cat 8. But they were significant limitations. Any operator who used this knows that they had no steerability because they were not angled. They were quite flimsy, so it was difficult to track. And basically, you attach this catheter to a suction tube. So you basically continuously exsanguinate the patient. So for the most part, for long kind of periods of uses, didn't really find a good use for them in the DVT space. Now, they've added a couple more things, and this has revolutionized, I think, the Penumbra portfolio. In 2019, they came out with things to address the issue of continuous blood exsanguination. This is intelligent aspiration. I'll show an example of that, where the machine can detect how much pressure is against the actual catheter, so it can limit how much blood loss they have. And then they made a tremendous amount of improvement on the actual catheter itself. It doesn't seem like it is because it just feels like another catheter you put, but the amount of technology in this catheter is actually unbelievable. It's a single stainless steel hypo tube that goes all the way, which makes it a little bit stiffer, which allows you to torque it in ways so that you can get apposition to the wall and get 360-degree sweep throughout the entire area. And I don't know if this will play, but they added this nice little audible thing where I guess the sound's not working. It clicks all the way through. Basically, if it is against very low pressure, it will not do continuous aspiration, but will do quote unquote intelligent aspiration, which sounds really nice. That's some good marketing. And as a result of that intelligent aspiration, you're able to reduce significant amount of blood loss during these cases, which was a big deal. You're putting in a 12 French catheter into a vessel and you're sucking out blood. So you need to be able to limit the amount of blood loss that you have in cases like this. And currently we're enrolling Bolt. This is the study that I mentioned. It's a prospective multi-center study of patients with deep vein thrombosis to evaluate the safety and efficacy of Indigo. It's across, the goal is to enroll 400 subjects across 50 sites. I'm happy to say we're one of the people who are enrolling in the study, and the primary endpoints will be the major adverse events at 48 hours, complete or near complete resolution of the venous thrombosis of up to 75%, and some secondary endpoints of composite safety endpoint, device-related adverse events, and you heard Dr. Desai talk about the Volta score and how it's being validated to kind of look at this in a prospective way. So we'll have more data coming to you soon. This is a case that was done at my institution. The first Bolt patient that was enrolled. Dr. Desai, hopefully you're happy with it. Here's a 46-year-old female, history of knee surgery. This was done by my partner, Angela Vuyuka, phenomenal partner and great surgeon. Had knee surgery 1.5 weeks prior, now coming in with 2 to 3 days of acute left lower extremity swelling, no other significant past medical history. And this is kind of what you would expect. Occlusive DVT at the common femoral vein, down to the femoral vein, all the way down to the popliteal vein, with some evidence of extension into the external iliac vein. And whenever we see that, we obtain a CT, and you can see that this is coming all the way down. And you see thrombus extending up to an area of May Thurner, extending into the common and external iliac veins. Also, you saw a pretty big kind of fibroid uterus there. We'll let that cycle through one more time. So unilateral DVT on the left side. So this has also been a shift for us. When we were doing pharmacomechanical thrombectomy, and angiojet was probably the biggest thing that we used, we would very rarely drop a filter. But in strictly mechanical thrombectomy, where especially in patients with a large clot burden, we like to drop a filter at the start of the case with the plan to remove them immediately at the end of the case, because you are shifting acute thrombus in an area without giving any thrombolytics. So the concern for PE is definitely present. So especially in large thrombus areas, we will drop a filter first. And then you can see we frog-legged the patient and got access at the distal femoral vein, distal popliteal vein. And then you can kind of see the thrombus that's all the way throughout the area, throughout the femoral vein, going up to the high thigh, and then extending into that left common iliac vein. We're able to pass the penumbra, and it's exactly as Dr. Desai had shown. You can get significant clot thrombus removal. And I show you, I don't have a good cine clip of it, but this is a cine clip I borrowed from a good friend, Martin Knowles at UNC Rex. Using the penumbra, there are some tenets of regular endovascular surgery you do have to kind of put by the wayside. Losing wire access was the biggest one for me to get my mind around. Typically, you cross the lesion and you leave the wire there, and you never lose wire access for every other vascular procedure. But in penumbra thrombectomy, it's important to remove that. It allows you to be able to use the entire diameter and the size of the penumbra catheter very well. This is a separator that you see going in and out, and mainly because if you think about the mechanics of this, it is a end-hole catheter, which means that as clot gets stuck to it, the end of the catheter can become plugged. So you're using a separator to try to clear that clot from the end of the area, and you want to be fairly vigorous. Now, I know it's scary when you push catheters without a wire. It goes against everything you learn in every other space, but once again, this goes back to the technology of where this company came from. This is a stroke catheter company, so they have very kind of atraumatic tips of these wires, and we've been able to show significant trackability of these without a wire, and it's been very safe. And you have to vigorously use the separator in these cases to make sure you're clearing the tube all the way throughout. And the specimen that you get, you have to have one of these pictures, because this is the sexiest thing during a thrombectomy case, and you can get very good kind of clot resolution and removal from the area. Finally, a lot of these patients will have some sort of underlying reasons. Sure, she had surgery. Sure, she had immobility for a while, but very rarely will these patients get a full-on DVT all the way up to the iliac vein. You have to check for the underlying lesion, which you can see some pancaking and flattening of the proximal common iliac vein with some collaterals. IVUS demonstrating May Thurners, so that ended up getting a stent to treat the underlying lesion. And then, yes, at the end of the case, we removed the filter. We didn't do it prone. That sounds quite challenging and really technically amazing. But we did all of this with the patient supine, so we were able to just take it out at the end of the case. And that's it. Thank you.